I am Andrew Tibbs. I'm the Senior Surveillance Epidemiologist for the Tuberculosis Program at DPH. Welcome to all of you. We're happy to come and answer any questions that you might have. We usually start out by giving a brief presentation on the kind of nature of tuberculosis as it relates to our situation here. And so if you'll bear with me for that. This feels very formal. That's not the kind of environment we're hoping to create here, so if we have questions afterwards, we're happy to stay as long as we need to make sure that you guys are comfortable. I will say up front, though, that we're not going to talk about anything that pertains to individuals. Strictly for privacy reasons, we ask that you respect that. But we'll talk about the process and how it'll work here, hopefully, going forward. Does that make sense? All right, so tuberculosis, also known as TB. It's a mycobacterial disease. That just means it's a bacteria. It's a rod-shaped bacteria in your body. Causes disease in some people. There are a bunch of others. TB is the most recognized one. There are two types of tuberculosis. Extrapulmonary, which can happen in basically any body system. Here's a map of some of the ones that you can get it in: your central nervous system, your lymph system, pleura, disseminated throughout your bloodstream. Bones and joints are in your genitourinary tract. And then pulmonary TB, which is the kind that everyone knows about. It's the kind from literature, the one where everyone coughs and you notice that people are sick. It's also the infectious one. So extrapulmonary TB is not infectious. And we'll revisit that theme a few times this evening. There are stages of TB that exist in a continuum. The first one is exposure. So in order to get TB, you have to be exposed to someone else that has TB, has pulmonary TB. And you have to be exposed in close proximity for a pretty long period of time, and that person has to be pretty infectious in order for this disease to be transmitted. It's pretty difficult to acquire in the environment, especially in an environment like the United States where there's not much of it. The next step, after being exposed, is that you may become infected. The recent risk factors are recent exposure. There are certain populations that are higher risk for being infected, and some comorbidities, other diseases that increase your chances of becoming infected. And then in some small percentage of those who are infected, you get sick. You get disease. And that disease, if it's pulmonary, will lead to symptoms, and then you become infectious and the cycle begins anew. So let's talk a little bit more about each of these stages. First is exposure. This just means that you've come in contact to someone who was infectious, and this exposure could have happened at any point in your life. About 10% of the time or less that you encounter someone who is infectious, you may become infected. Infection. So TB bacteria, this just means that TB bacteria have entered the body. It also means that for the time being, your immune system is sufficient to contain that infection. It walls it off inside your body and you aren't sick. You can't pass the disease on to anybody else. And you can live that way your whole life without ever knowing you were exposed. It's most commonly called latent TB infection. You might hear that or see that doing research. That's what LTBI stands for. And our points to remember for here, as I've said, are that there's no symptoms. If you go into a doctor and get a chest x-ray, which is the next step in evaluation for TB, the doctor won't see anything on the x-ray. You have a clear chest x-ray, and you're not contagious. And at this stage, tests are available to determine if you are infected, and treatments are available to prevent you from getting the disease in the future. And again, here about 10%, probably less, who are infected ever go on in their lifetime to develop disease. So TB disease. This means that your immune system is no longer sufficient for some reason to contain the bacteria, and the bacteria start to multiply in your system. And once they multiply enough, you become symptomatic. You might, if you have the disease in your lungs, have an abnormal chest x-ray. And if you have an abnormal chest x-ray, that's one of the signs that you might be contagious. You could pass this disease on to somebody else. However, again, even at this stage, tests are available and treatment is available. So let's talk a little bit about infectiousness. A person, even who has the disease form of TB, has to have a site of disease in the pulmonary, in your lungs. You have to have the disease in your lungs in order to be able to spread it. You have to have symptoms. Even if you have the disease in your lungs, if you're not coughing, you can't spread the disease. And you have to be on treatment less than 2 weeks. Once you're on treatment for about 14 days, probably even less, you can no longer spread the disease to other people. Types of transmission. So you can get TB. TB can be spread by droplets, so from person to person through droplets in the air. Coughing, sneezing, singing, in combination with prolonged contact, can transmit the disease. You can get it from casual handshakes, indirect surfaces, sharing food or beverages, and usually you can't really get it from short interactions. So risk of exposure. So these are the three things that I mentioned at the beginning. So in order to become infected from an exposed individual, you have to be in close proximity with them. The way we like to, the example we often give is that you have to be in an enclosed face-to-face space about the size of the back of a taxi cab. So it's pretty small, pretty close physical contact. Obviously it doesn't have to be enclosed, but that's the kind of face-to-face direct contact that we're looking for. You have to be in contact in that close space for up to 8 hours. So that's cumulative, 8 hours over the entire period of time the person was infectious. And the person has to be infectious. So how infectious they are impacts how careful we consider these other two factors, proximity and duration. So as I said, about 10% of exposed individuals go on to develop infection. 10% of infected people may progress to disease, probably less with healthy immune systems. Chances are slightly higher that if you are infected, that you might go on to develop disease in the first 2 years. There are certain high-risk populations, substance abusers, prisoners, homeless folks, children, young children, frequent travelers, and some healthcare providers that are at higher risk of progression. Also individuals with comorbidities, diabetes, HIV, hepatitis, some smokers. Those are all have a chance of increasing your risk. There are two different types of tests for infection. So one is the tuberculin skin test, or TST. This is the one that's been around for a long time. So it's an intradermal planting, which means they put a droplet of solution between the layers of your skin, and then they come back and see if your body reacted to that droplet 48 to 72 hours later. It's appropriate for all ages. And this is a picture of how they react. There's a blood test, which is a more modern test. Doesn't work any better, but it's more modern. It's been approved now for down to 2-year-olds. It's preferred for those who have been vaccinated overseas with BCG, the tuberculosis vaccine, because it doesn't cross-react. And it's just a simple blood draw. So you may have heard about the vaccine. So BCG is the vaccine for tuberculosis. We don't use it in the United States because TB is not really a big enough problem here to make it worth the risk. It doesn't work particularly well. The vaccine is good for very young children and prevents mostly the worst type of TB meningitis in young children, and then the immunity that they receive from that vaccine wanes over time, and they become as susceptible as the rest of us. And it cross-reacts with the TST, the intradermal test, so a lot of people think that if they have a positive intradermal test, it's because they had BCG as a child, and while that may or may not be true, in those people it's easier to do the blood test because it helps us eliminate that confusion. If the tests, either one of those tests is positive, the next step in the evaluation process would be to see a doctor for a chest x-ray or a CAT scan. And then if the x-ray is abnormal or they have other worries, they might do laboratory studies. So smears, there's TB bacteria in the upper right there, or culture, which is TB growing on an artery plate. So let's talk about contact investigation. So that's what Nicole and I work on. We take all of these clinical indicators, sites of disease, symptoms, onset dates, laboratory radiology studies to determine someone's infectiousness. And we work through concentric circles of people who have that proximate exposure to the individual and work outwards through various settings, considering environments and classroom sizes and all of that to determine who is most likely to be exposed to that individual. We do 2 rounds of testing. So we do a first round as soon as we can after we identify who needs to be tested. And then if they're negative, we'll retest them in 8 to 10 weeks. And this allows us to determine if transmission is occurring in that setting and lets us know if we should expand the scope of our investigation or take other measures to do more work. And then post-exposure testing, that's the one in 8 to 10 weeks. We prefer to use the same method for both tests. So if you get tested with the TSC the first time, you get tested with the TSC the second time, same with the Viagra. The results, if you're positive on either test, are the same. You go get evaluated, and hopefully you'll elect to be treated for the infection, which will then reduce your risk of developing disease in the future. And just a little context. Something between 1/4 and 1/3 of the world's population is infected with TB. That's 3 billion people. Again, most of those people will go their whole lives without ever knowing they're infected. There are 9 million new disease cases in the world each year. Only about 10,000 of those are in the United States. That's 1/10 of 1% of all the TB in the world is in the United States. But it is the #1 infectious disease cause of death in other countries. And so, why we do what we do is to prevent that from happening here. And so I'm here. Again, my name is Andy. My colleague Nicola, who's the point person on this investigation, is here, and our medical officer, Dr. John Bernardo, from the TB program, are here, and we're happy to answer questions. I think I'm gonna stand down here though, so I don't feel so official. Who has questions? Yep.
I was just wondering, have you identified kids or teachers or whoever in the school system that need to be tested?
Yeah, we're working through the last phase of that process now, and we expect that either tomorrow or early next week, we'll send notifications out to those people who identified as being exposed through the school. So you get the notification from the school. If you don't get a notification, we haven't determined that you or your child are at risk for this round. That doesn't mean you wouldn't get a letter in the future.
I might be a little behind. Has it actually been confirmed to be tuberculosis?
Yes.
Okay. And has it been typed for drug resistance?
No, that part takes a little while. It hasn't come back yet.
Okay. And when you do find out, would that change your epidemiological parameters in terms of if you did find it was one of the resistance strains?
No, it wouldn't change the scope of the investigation. It would change the advice we would give to the clinicians who are doing the evaluations for anyone who would test positive. Yeah,
What are the symptoms and how long would it take for it to manifest? Especially with that.
Yeah, so symptoms for TB disease. So again, TB infection, if you're just infected, there are no symptoms. TB disease has a variety of symptoms. The most common ones, and again, some people have them, some people don't, are coughing tuberculosis, which means you're coughing up blood. Severe weight loss, greater than 10% of your body weight, which is not expected, you're not trying to diet or anything. Night sweats, swimming in your sheets, not like casual, oh, I got too many blankets on, but like really waking up, feeling like you took a shower. Malaise, other flu-like symptoms, malaise.
If it is that far progressed, that it should be still effective.
Yes, for most people.
There was a story reported on March 6th, that's just 2 days ago. Aurora, Colorado, are you familiar with that situation where the first round of testing of the concentric circles yielded no infection, but the subsequent 8 to 10 weeks later revealed many infections?
Yeah.
So now they're testing the whole population.
Yep, and if that happened here, that's the same thing that we would do. So the first round, it takes about 8 to 10 weeks. That's why we wait 8 to 10 weeks for your body to build a reaction to a recent exposure. And so what that would tell them is that first round, they tested. Very few people tested positive. The second round, more people had a chance to react to the bacteria. That means that some transmission probably occurred in that setting. So that's why they're taking the precaution of testing the whole population at that point.
And then one more question.
Yep.
What guidance has been given to staff here at the high school in terms of what sort of things to be looking for? It was reported to me by 2 students, neither of which is my own child, that in a particular classroom was a student that consistently coughed and was coughing blood.
So we did a presentation for the staff here yesterday, same as this. So
And do they have specific instructions on how to report these sorts of observations? And do the students have specific instructions on, as to how to report those observations, other than to their parents?
So, I mean, I would turn that one over to the school administration.
So typically what happens is, not even long before there's anything that we're actually watching for, teachers will send kids down to me. Oh, this person just doesn't look right, they look sick, they've been coughing for a while. So not specific to potential exposure, but teachers always send kids down to me. Our hope was that students would attend this information session to get, so that we could speak to everybody all at once. So other than the letter that was sent out by Allison to you all, that's the information that's gone out.
So the students have an information session on what this is and what to look out for.
No, not specifically for them. No, they have not.
So I find it very concerning that I'm in the supermarket and I've learned from other students, and I confirm with my own daughter, that another student who's different than the student who is no longer at school right now is exhibiting very concerning symptoms, and they seem to not know any way to report it, and that's why I came here tonight, to tell you that, and I'm very concerned. I don't know how the concentric circles were drawn, but in who's getting tested and what tests are they being tested at school.
Yep, so,
So this information, and I just want to say, so I'm working with the health nurse, and I have been working, and to be perfectly honest, it's just right now that I heard that it was actually technically confirmed. Because we've been, I didn't check in data today, but so I'm learning here that it's officially confirmed through the lab. So I just wanted to explain, that's why you haven't heard anything from me. Every time I speak, I've said that we've been waiting for lab confirmation through DPH. So I don't want anyone to think that I'm withholding information, because I just learned that myself this evening. So
yep, so the plan is for testing, there's always options. So we're going to offer testing through the DPH hospices here at the school in the next couple of weeks. We're shooting for Tuesday, the 19th of March, for the first round testing here. And so students can do the testing here, or they can go to their primary care physician, or if they've already been tested recently, we can take those results in some cases. And then we'll do another event here for the post-exposure testing in 8 weeks.
So you're trying concentric circles around one student, but have you done any other survey of the rest of the Wayland High School student population to see if there's anything?
Yeah, so I actually came here with the nurse assistant to this case, and we did a walkthrough through the school to look at the size of the classrooms, kind of identify the populations that we're looking at. And the concentric circle, like you mentioned, so generally those start with household, but whenever a school is involved, we do want to be extra cautious, and when we do the first kind of concentric circle, we include the school, because we know that there may be vulnerable populations. We also kind of broaden our, the scope, the, network casting. Usually the recommendations by the CDC is that it's within 3 feet of proximity over 8 hours. We usually go further than that. We'll do 6 feet and we'll do 6 hours. And majority of the time we do have schools and we have regular sized classrooms, we'll just include the whole classroom, just because we want to make sure that we capture the what is kind of. So we'll take the required or recommended population by the guidelines that are in place, and we'll go further and take more.
So if, let's say, for example, a student is on a sports team and they have 20 different teammates, and those 20 different teammates are in different classes.
So there's no way to give it, you have to be with the person that has the disease to actually be able to get infected. If you touch the surface, if I talk to Dr. B and I'm sick and he goes talk to someone else, there's no way that he can give it to anybody else. You have to have symptoms and give it. The bacteria is droplets, and once it's expelled into the air, unless it's inhaled by somebody else directly within the amount of time it takes to fall to the ground, then they're not going to pass it on to anybody else.
And are all strains of TB equally infectious?
No, let me answer that. Maybe go back to the previous question. When you become infected, you generally are not infectious. So if I become infected with TB, during the time that the bacteria is infecting my body, my immune system is learning to recognize TB, to be able to respond to the skin test or the blood test. You're not infectious. So I would take a student who's not really exposed to this person who's ill and evaluate. He or she needs a medical evaluation. Maybe it's asthma, this is the flu season. These things are probably more likely than TB, but the child needs an evaluation if he or she is sick, especially in this environment. As Andy has said, TB is not the flu. It's not highly infectious. You need a relatively prolonged exposure to somebody who's actively coughing and producing a lot of organisms into the sputum. And so we weigh these things when we go and set up our contact investigation. It's not perfect, but we do the best we can with the tools we have.
It's just concerning that in a similar high school in Aurora, Colorado, where there was very, you can draw some parallels. Many people were infected by one student.
Yeah.
And so, I hear you that it's really hard to catch, but at the same time, we've got a high school a little bit west of us that has many parents with very sick children,
Right.
or infected children,
Well,
who haven't yet gone to the disease stage.
right. But
I'm
then
just an engineer, I'm not a nurse, but
no, I was an engineer before I went into school too, so we would come from the same line of thinking, I think. But if we find there's transmission, even suggested by the first and second round of testing, we expand the circle. And the word gets put out that if somebody's ill with a chronic cough that's not explained, the person needs to be evaluated for clinical disease.
But again, there's many reasons that there could be coughs in this time of year, and the cough has to be prolonged. Up top.
My question is, I just wanted to clarify, you are including the sports teams?
We're including anybody that the index patient may have had contact with for the duration that we have set and the proximity. We can't give you any specific groups that we're including or not including, just because that is specific information about the patient which is covered under the fund. We can't give that out.
But I have to say,
So if there is a group that child spends, like, how many hours? I guess, how do you?
Yeah, so if you do that,
Like,
I hear what you're saying.
I'm not asking for you to say what team or I
Yeah,
understand.
so
What I'm saying
hypothetically-
is, would that be in your calculation?
Yes,
Yes.
A group that the kids spend 10 or more hours a week with?
yes.
Okay, thank you.
So that 6 to 8 hour period, is that cumulative?
Cumulative,
Or is that
yeah.
at one point? So
No,
maybe
cumulative.
2 hours over.
Could be 15 minutes, 800 times.
Okay. And then that's.
and as I said before, the first circle is typically, I think, relatively, it's here. We are testing here. We are being so, generous is not really the word, but that's what it is, really. In fact, we are going, at their recommendation and at our request, sort of, not really, but to really truly test anybody that might even possibly have gotten exposed.
Can you describe the treatment of, not person with active disease, but if they have it, that's
Yeah.
been infected, and whether that's an experiment capacity?
They can't drink.
Anyway.
There are 3 currently approved regimens for TB infection, and which one you get depends on your ability to tolerate medicines. They're all antibiotics. So there's one 9-month course of isoniazid, so INH we call it, once a day for 9 months. There's a 4-month course of rifampin. Obviously, we prefer shorter regimens. And then there's a newly released regimen, which is a 2-drug regimen, once a week for 12 weeks, called 3HP. They're all antibiotics. They're all have some side effects and some. You have very specific questions like
And then they just sort of go about their business.
Yep. It reduces the chance of developing active disease from the 5 to 10% that it was before to well below 1%. Yep.
Just protocol. So when you identify this group of people that should be tested, would you be talking to this group of students as well? Or would you be that combining spirit? Let's say my child happened to be one of them.
At the moment, the communication is planning to go to the parents.
And so this is where you get the letter from the public health that says your child could have been exposed to
Yes.
X, like the pertussis.
Right.
It'll actually come from the school, though, not from.
In this case, it will come from the school, but it will sound remarkably similar to that.
Because we're getting it from
That's
them.
2 years ago, so it's like.
Yeah.
Question, what do you do for prevent what happens when this child who was exposed and was seriously infected, he was around all these 3 days. How you guys protect it? What do you do it?
How do we keep it from happening
Yeah,
again?
because, you never know where he's coughing, where he's sitting, and you check kids who is coming after him. It's very contagious, and I don't believe that 8 hours you're supposed to be in a car. It's enough just coughing from front of you, close to like vaccine, distance. And I don't believe it. It's like 8 hours. Because I come not from third country, I come from Central Europe, and I know Even I was, have a BCG, whatever. Yes.
Yep.
And I'm okay, but even I 3 weeks, my daughter coming from school, last day after vacation, started to be sick, and she said like, have school, coughing, sick kids around. Now I catch it 3rd week, I couldn't stop coughing. I make an appointment, wait, now my appointment, I don't know how to finish, but I try to understand how you prevent, how you clean it, what you do, because usually if it's some kind of epidemic, whatever it is, that it's supposed to be disinfected, some kind of, to protect other kids.
Yeah, that's sort of question.
Contagious, even plus, if disease could be like somebody can be infected, somebody could be carried. Just only all our life, like you say. And he never be sick, but he can contaminate others. People.
Yeah, so,
What you
again, I want to
do
really,
with these 3 buildings and buses, kids go in a bus, elementary school, middle school, and high school.
yeah, I'm gonna let John do the main part of this question, but I do really want to stress that if you're
It's
infected,
not stressing, it's just, I want to understand because it was surprise.
yeah, if you're infected,
So
you,
notes and everything, and now some other my co-workers, kids who attended high school where they say that some students cover with masks and work. I said, okay. For what? People, the kids scared or what?
yeah, so if you're only infected, there's no way you can pass that disease to them. But, John.
But I just want to understand how you protect these 3 buildings and buses and everything, because kids go in a bus.
Well,
It's coming in a class where these people sit. And, you know, it's a long term to realize when it's the incubator period.
Well, the incidence of TB in the United States is very low. It's a historic low point. It's under 3 cases of tuberculosis for every 100,000 people per year. So and that's about what it is in Massachusetts. One of the reasons for that, and we have countries around the world where the case rate is 100 to 1,000 cases per 100,000, including or countries in the Far East and Central Europe, Asia, and South America. And one of the reasons we have such low case rates in the U.S. is that we put into place a public health infrastructure that tested and started treating people with preventive therapy if they were infected. Now, TB has become so rare in the U.S. that we don't test everybody anymore, because when you test somebody with a test, like a skin test or a blood test, and they're very low risk, then the likelihood of them having a true positive test, if it comes back positive, is much less than that being a false positive test. So the U.S. Preventive Services Task Force 2 years ago decided to make screening of people who are at risk for tuberculosis a Class B condition, which means that it's covered by the Affordable Care Act without copayment and charge to the patient itself. So it encourages screening of high-risk people, and that's the major thrust that we're making in the Department of Public Health, to get out to primary care physicians and providers and getting them to identify that the high-risk people, students and grown-ups, and get them tested, and then prescribe treatment to prevent TB. TB is a preventable disease, and the way we get rid of it, especially in a country like ours, where the incidence is so low, is finding those high-risk people and giving them medicines to prevent it. I've been infected. I was probably infected by my grandfather when I was a kid, and I took a year of 12 months of isoniazid. The recommendation now is 9 months. But it's a preventable disease, and that's a good thing. That's the good news.
Okay, but what you do with buildings, with buses,
Well,
would you plan it?
If somebody's sick,
Coming positive.
then if somebody's chronically ill, they need to be seen by their physician or provider.
And it doesn't survive in the environment, so.
Yeah, you can't get, it's got to stay in the air in droplets that are moist, that are wet. Bacteria doesn't land on pens and get transmitted that way.
And I confirm what I thought I heard you say during the presentation, is that if you have someone that's exposed, if you have someone that's infected, but they do not have the active disease, meaning that they are not contagious.
Yes.
Did I hear that correctly?
It did.
Yeah.
So if people are coming back testing positive, it doesn't necessarily mean that they're contagious.
Right.
That they have been exposed.
Yeah.
But even if you're around them, unless they're active disease, coughing, they're not contagious. Correct?
Also know that there's a really bad cold going around the school, and kids are coughing from that for an extended period of time. The difference there is that they do get better. So we can tell the difference over time, and we're testing out so far that we're going to find people. We're going to find.
You mean if they have.
If, big if, big giant.
Identify people because we know that they.
No, if, big giant if, we will, because we're testing, our testing is going out so far, we'll be able to identify people that did get infected. And it's really that cold.
Another question? Yeah.
So we have in Massachusetts, so there was Aurora, Colorado, two days ago, Durango, Colorado, then Lawrenceville, Georgia. All these high schools have students with tuberculosis and are in the process of testing hundreds of kids. Is that, you just conveyed some statistics that make it sound like this hardly happens in the US, but it
Yeah.
seems like in the last couple of weeks, there have been a good number of high schools. Is there a national increase?
So you named 3 high schools. How many high schools do you think there are in the United States?
I don't know, I just noticed from Googling, I'm sure there's probably more, you know, and is this normal? Is this, you know, is there a new strain that's out there or potentially that we're?
We haven't seen an increase, so.
So one thing to add to is that it is the winter, so lots of people are sick with the cold or flu, things that are taking effect on their immune system. And TB is opportunistic. You can live with it for, you know, if you're a healthy individual, your immune system will contain the bacteria and you may never get sick. But if someone is battling something else and their immune system is weakened, that's where it could pop up. So it is maybe, you know, we don't know all of US statistics, you know, down to the T, but it's not unheard of that in the winter when people are battling other things and their immune system is taking a hit, that there may be like, you know, one extra case or something like that.
And the question about whether infected people are infectious or not is another good question, because, you know, we might find another active case. If that person was infected a while ago and has not been able to contain the initial infection, then that person might get sick with TB. So that's why we do the clinical evaluation with an X-ray and a physical exam and a symptom check whenever somebody identifies us who's infected. So that's why we put it through this.
I'm just kind of curious, that do you always have to treat TB with medication to get better, or is it something that some people fight off?
Yes, TB disease, we definitely aggressively pursue treatment. TB infection, people can elect to take the treatment.
After TB though, is that something that somebody could cough and then get better? And no one ever knew they had it?
Yes, yeah. Before there were antibiotics, and the first drug that was targeted for TB was streptomycin in 1941. So before that, there was no treatment for TB except for the sanatorium. And
Not everybody got it.
no, 50%. 50% of the people died. 50%
Even in
survived.
the United States, before we spread it.
Right, TV's been around since like the Egyptian times. Days of the Egyptian pyramids. That's why we're so.
I was just curious if you get it, if you got it, but you don't.
No, no. That's about 50%.
Pretty serious.
Yeah.
That's all right. Okay, if people has allergy for antibiotic,
I'm sorry?
if people has allergy for antibiotic, okay, what they do?
We use other antibiotics.
Yeah,
Yeah. Yeah, we have a string of medicines we can use for
they have
TB.
viral.
Yeah, yeah.
You know, in this case, if the person was infected years ago, or was recently infected?
We don't know.
Yeah, there's no way of knowing when you actually were infected. I wish that was even really old.
Yeah, I don't know when I was infected. I was probably infected when I was a kid because I lived in the family with my aunts and uncles all in one house. And my aunts were infected also.
But one of the reasons we do two tests as part of chronic investigations is that in some cases, we can determine between the first and the second test, if someone goes from a negative to a positive, that infection occurred sometime in the last 8 to 10 weeks. So that's what lets us know, okay, someone at this X setting was transmitting TB.
Sorry, once you come up with the group that you want to, or that you suggest get tested, is it a suggestion? So basically, if, you know, if you're going to test 100 students and teachers, et cetera, is that mandatory? Like, what about the kids or the teachers that don't want to get the test or refuse? Is that a thing or no?
It's strongly recommended.
Okay.
Some school districts choose to make it mandatory, but the state has no requirement for that testing.
I don't know if you missed this, but do you know the amount of time the person was active, or are you able to figure that out and figure out, use that information for how?
Yes, I can't speak about this person, but in general, we look for either the earliest onset date of symptoms that we can determine through interviewing both the case and people surrounding the case, and then go 12 weeks before that. And if the case doesn't report symptoms or doesn't seem to have symptoms, we'll go 12 weeks before the earliest positive test for TB.
And we bend that a little bit. We'll go further back if we have to. We don't usually go shorter than 12
Yeah,
weeks. But
all of this
yeah.
is flexible depending on how infectious the person looks or how many high-risk individuals are in the populations we're surveying.
Yeah, there's several variables we put into this.
How many cycles are there, how old the building is, how many cycles each classroom has, all of that goes into the calculation.
Can you count things like bus rides?
Again, if it's a group of people who spend that much time with the individual, we would count.
So if you enclose spaces, that pool, is the microbacteria, would it be killed by the chlorine in the water, or is
In the
that?
water, probably.
Probably will, yeah.
But in the air.
You have to
But
inhale it.
But you have to inhale.
Yeah, that's why it's the airborne thing. You have to be with the person close enough to actually have them expel it into the air and you inhale it.
It has to
You
get
get
through
through the food
has to get through the booby trap that is your mouth, down your esophagus, into your lungs, and over.
Kind of gross. Yeah.
Yeah.
So if somebody who's has active disease pops on the lunch line in front of another kid's face,
It's possible.
It's possible, but I'd be more worried if that kid had the flu than if he had TB. If a kid would get the flu. Because flu is much more infectious.
I have a question.
Yeah.
We have band, we have, like orchestra, everything. We have now concert for next week, all, schools. How it's possible? How it's contagious?
she's saying, there's a lot of multi-school, lots of, several of the next week.
We have band,
Like rescheduled where basically the whole school system
Concert.
comes together. So I think you're asking about the probably, the
Like,
possibility. That
yeah,
large.
kids going to like different classes, different, like grades going together, and they play, for example, now they practice certain one. If somebody who's contagious or whatever, in a race, how it's possible across the instrument and
To the best of our knowledge, there's no current risk of exposure here at the school or to any of the
But that's why we're testing.
So how many students did you test in the first round?
We have that
Or you haven't done the first round? How many do you anticipate testing?
I'm not going to share that.
How do you, so you mentioned that you take into account how infectious the index case is, based on like, probably sputum concentration?
Yeah, so they look at a bunch of things. One of them is sputum smears, so they'll look under a microscope and literally count how many bacteria they see. The more they see, the more the person coughed up, and thus potentially the more contagious they are. They look at the chest radiography. If they see advanced disease in your lungs, you're probably more contagious. Things like that.
What test more accurate? Blood test or X-ray or? What is more accurate?
Depending on which stage you're trying to test for.
Early in the stage.
Well, it all works together. The symptoms, physical findings, X-ray, laboratory tests, they all work in concert. They help us establish a diagnosis of infection disease.
You guys do all
Yeah, it's a process that we go through. It's pretty standardized as it is. Yeah, and people who have negative smears, if they stain the sputum for TB and you don't see it, they can be infectious also. So, it's not a one-to-one.
And we still do this if they have negative smears. If
Yeah.
there are schools and we'll go and we'll do, it's still the same. The moment that we hear that there is a population that could have been exposed, we will do these content investigations until they're proven that they're not contagious.
How many ongoing investigations are there in Massachusetts right now?
I'll say that there is, on average, 200 cases of TB a year in Massachusetts. Not all of which get full investigations, but
That's because not all of them are lungs. So 200 of any.
How many are lungs in a public school setting?
Well, we just-
For non-high-risk populations? Not on average, like
well,
in the last year.
I think the number is so small. Let's put it this way: the number is so small, I can't give it up because you could potentially identify individual patients.
But we see it everywhere. We see it in colleges. We see it in schools like this. We see it in congregate settings like shelters for homeless.
That's a high-risk setting.
Websites,
Some places, some settings are, some of them aren't.
office buildings, laboratories.
Yeah. Yeah.
It's not uncommon.
Yeah, I worked at Pine Street, the shelter in Boston, and there was a time we were getting cases that are there at a tremendous rate. And now the last case we had at Pine Street was 4 years ago, 5 years ago, because we put in a preventive therapy program, a testing and prevention program in there, and with the education of the guests, and the preventive therapy program we put in there, and probably a change in demographics, the population probably changed. We knock on wood, we haven't seen a case there in a while.
When you say you've educated them, what did you educate them?
Well, if they start coughing, it doesn't go away, fevers, weight loss, pain, like a lymph node growing, they should come and see us. And we take care of them. And it's all about developing dialogue with the patients. And so we need to know if somebody's sick with a cough or fevers or sweats that it's not going away. We need to know that. And the problem comes when somebody's sick for weeks and weeks and weeks and just doesn't do anything about it. Because then they expose other people to something like TB or the flu gets better. TB, not for a while anyway. Yeah.
So I would like to recommend that our high school students are old enough to understand this and to self-advocate and protect themselves. Their parents are part of that equation, but we're talking about you know, mature young ladies and young men, and, you know, I think it's important that they know about all of this, and that they report concerns to the school, because right now, they don't seem to be aware.
And kids should know, and grown-ups should know, when you cough, you cover your mouth and nose. And that cuts down on transmission of anything. Wash your hands. We share classes with somebody who's got a runny nose, that kind of thing. There are lots of public health education that needs to be done, and be taken seriously.
We actually have some students come tonight, so that's part, you know, right or wrong, that was sort of the thought process. So we were hoping to address some of those needs, but I do get what you're saying.
Really, it's about, honestly, I don't see the instructions for TB as being any different than for any other respiratory disease or gastrointestinal. You know, if you're sick, and we say this all the time, if you're not well, please don't come to school. Please stay home until you are better. And if you don't get better, then go see a doctor. And, you know, I think that's information that is important regardless of what is going around currently. And I hope and I think that the kids actually have gotten that message, not specifically about TB, but just in general. If you're sick, please don't come to school. And if you're here, please go home. My threshold for sending people home is so low. I agree.
Especially, obviously, there's at least one student has put the whole school at risk, and that promises very much.
I agree. Then say it to me.
Anything else?
Just next steps. So the next steps are to, if your student is contact, you'll be notified,
Yep, soon.
and with clear instructions as to how that student will be tested,
Correct.
following plans are after that.
Yep, and if you have any questions upon receiving that notification, you can communicate either with the school or with the state health department, whose number will be on there.
And that's done through the state, or that's done locally through the local health department?
If we all work together as a team, so if you contact any person in that triumvirate, the school, the locals, or the state, we will all communicate.
You'll come here for testing?
Yep, the testing time will be out.
And on the information for anyone who's anticipating that they may feel like they're on the contact list, when we get the contact list and we can distribute the information, you will have the information regarding the date of the testing, and we need parent permission, obviously. We're looking to do blood testing, if right on the school, or we can do the planting of the skin testing in the school environment, as long as people are comfortable with that. Meaning, if you don't think that that's a good place for your child to have testing done, then you certainly are welcome to take your child, you know, to their physician, or, you know, but what we want to do is just try to make it as, what we hope is easy and convenient, if that makes sense, for people. But we obviously cannot do anything without parent permission, for those under 18. We would not. So that's why the letters are going directly to the families, because they are the ones who have to sign the paperwork. And the paperwork will have to come back to us before the on-site testing date, which, from what I understand, is we're shooting for the 19th, but we're waiting for that date to be confirmed, so DPH contracts with the lab. So they're trying to get the date on the record so we can put it in the letter, or, you know, the letter that goes out through the school. So that's, and I appreciate that some people may feel that it's taking a long time to be notified, but the reality is, with the amount of time, right, because the germ is so slow growing, even the first round of testing, if anything, we're, right, well, so for the first round of testing, we don't want it to be too soon. You know what I'm saying? So this way, we're actually going farther out, which will really ensure that we capture someone who may have TB germs in their body.
So if you're in the first round of testing, you'll then also be tested again?
If you're negative, you would be tested for a second time.
The
If
same
you're
group.
if you show positive TB germs in your body, which does not mean that they're in the lungs, we would do the same process, which is ensure that there is a medical evaluation. Typically, we would call, either myself or Amy would call, talk to the family, and determine where you want to have that evaluation set up, and have a chest x-ray and a symptom review. And then next steps after that. If you're negative the first time, we would absolutely want to test the second time. And that's where it's suggested that if there's blood testing the first time, then we would recommend blood testing the second time. And that means the lab would be coming on site the second time, or all PPDs, it's called PPD, which is the protein that we put under the skin, and it binds with any TB germs in the body. And we would do that as well. So the plan is that we would our goal is to try to have everyone done around the same time, just in terms of tracking. But, you know, we certainly want to respect families, you know, choices on what works for their family as well. So,
We could provide insurance information if they're tested.
so the
So
request is.
we'll ask you to provide insurance information. The company we use will use the insurance information, but there will be no charge to you or the student. So what the insurance doesn't pay, the state pays for. If you come here for the testing. If you go to your own private provider, you pay your normal insurance, co-pays, etc.
Right, many of these are my flu family friends, right? Everybody knows me from flu clinics. So what I would say in a positive way. I guess what I want to say is similar to how we run flu clinics, there's no out-of-pocket expense. That's really what the situation is. So we request insurance, but regardless if your insurance pays for it or not, service will be rendered and no out-of-pocket expense for your child or whoever's been identified on the list.
Unless you go to a private provider. Again, I'll reiterate, that's fine, but you pay.
But you do initially choose either the skin test or the blood test, and then you stick with that test.
Yeah, so we're hoping that people will choose the blood test just because it's much more straightforward in terms of eliminating BCG and all this other
They don't have to
confusing
come back for
factors.
reading.
Yeah, because for the skin planting, it has to be planted, and then we have to actually read the test 48 to 72 hours.
Yeah.
So, right, so with whoever is skin tested, I will be back to read it, but if a kid doesn't come or they're out sick that day and they miss that 72-hour window, the test actually has to be repeated, the skin test.
And so with
I'm
blood
sorry,
tests-
I was gonna say, like, in a way, the blood test is, you know, right now they're talking about, the Prevnar 13 one and done, so that's what I consider the blood testing. It's sort of one and done for, the first round, and then it would be one and done for the second round if they're negative. Meaning that you don't have to come back, blah, 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 blah. You get notified of the results, but you would receive a personal, reach out, either through Amy or myself, if the result is positive. But what I want you to know is that all information is confidential, and that means that that information does not need to be shared elsewhere, and we work with your, provider in determining next steps. So, we always do try to keep confidentiality and privacy as foremost as best as we can. I'm sorry, I just thought it was, good opportunity to sit and do this.
That's good. Thank you guys.
Thank you for coming, you guys. No, no, it's good.